to everyone for being here. We're going to introduce this session, Strongholds of Heroin Addiction and Treatment Implications. It's presented by Paula Dranger, who is not only a licensed clinical social worker, but a certified substance abuse professional. She hails from Maryville, Indiana, and works at Valparaiso University. Thank you, Paula.
Thank you very much. One of the things I do in terms of working with addictions is I began the licensed clinical addiction counseling certification in the graduate school at Valparaiso University for people who want to prepare to sit for their LCAC, which is the licensed clinical addiction counseling. And I work with drug court, as some of my clientele who are going through it. We have an 80% success rate with our addicts, but I will also tell you that they get, it's an 18-month program at a minimum. We've had some that they're 4 years. That's the exception, that's more the outlier, but 2.5 years is just absolutely normal. Because they have to go through everything in order to be done through their phases. They get drug tested at least 3 times a week. So people could lie right to me and I might just buy it for a while. I won't buy it forever, but I may buy it for a while. So anyways, I've been doing this now. I have a company, Choices Counseling Services, that we do. We work with the court system. We're now going to be working with DCS, with people who are dealing with addictions, because they're finding they're spending hundreds of thousands, millions of dollars actually, all together, and they're not having any success. So we're working with them and creating a new program. And we're also going into the jails. What I first want to talk about is to show this in terms of it's the basal dopamine output. Okay, so the dopamine is the feel-good chemical that we have. So with food, and I'm going to read you what the numbers are. It's relative, because I want you to get a sense of what we're dealing with. Food is, so you have a pizza, 150 is the basal output. Now, if you notice, it takes a while, and then it kind of spikes, and then it trails off, and it lasts for a while, okay? Now, sex, all right? It's up to 200, and there's a quick spike, and then it lasts for a while. And everybody who does this always says that, well, if you have pizza and sex, who knows what this goes to, but it goes up. Okay. But here's morphine, all right? Morphine goes up to about 175, and if you notice, it lasts for quite a long time. It's up there for quite a while before it starts to go down. Now I'm going to be showing you meth in a little bit, sorry. So here is nicotine.
Would you push the screen forward?
Oh my gosh, I'm sorry.
That's perfect.
Yes, and there's that high. It goes up and then it goes down pretty quickly. Okay, so its effect, it will taper off. Once it goes down, the taper lasts longer. But now I'm going to show you meth. Okay.
Excuse me. What's the blue line as opposed to the red line?
They're either the serotonin or dopamine.
Okay, so blue is serotonin and red is dopamine?
Correct.
Okay.
Cocaine. Okay, I want to get to that meth. I'm sorry. Cocaine, we're up now at about 325, 350. Okay, and if you notice it, then there's that high spike. It starts to go down, and then it tapers a while, but then it goes down. Okay. All right, there's meth. That's at 1,100. Cocaine, 350, 400. Meth, 1,100. Your brain is not prepared for that kind of activity. And if you look, it goes up and then it goes down. And so when you begin to realize the effect of that, the hijacking of the brain, you can begin to see how that happens. Heroin's up there too, but meth is it's actually the harder drug.
Where is heroin?
Where is it?
In
It's probably about 500 to 600. Yeah, it's higher than the cocaine. Okay, and there it just kind of shows you, but again, this is 1100. Okay, so let's talk about the opioid epidemic. And 130 people, I think it's up to 175 now, die every single day. And one of the reasons I think that it's gone to the 175 is the fentanyl. Okay, fentanyl is 50 to 100 times more potent than the heroin, and carfentanil is 100 times more potent than the fentanyl. So, and we had kind of talked about, there's no good housekeeping seal of approval in terms of what's being put in the drugs, and it's getting more and more dangerous because there's more and more lethal type things that are added. Now, the thing that made me the saddest is to hear somebody who's addicted to heroin that says when somebody overdoses on heroin, everybody wants to get that heroin because it's so good. Come on in.
Sorry.
Yeah, no problem. I mean, because
You mean the heroin that the person that overdosed took?
yeah. Because they go, then we know that's the pure stuff. That's good.
Just have to adjust the dose
Yeah.
safely.
Now, we're not just even looking at heroin, we're also looking at opioid prescriptions. And what ended up happening is the manufacturers said that as long as you're taking it for pain, you can't get addicted to it. That was the thinking. I mean, that was what it was said. Yeah. And so so people were on it. Now, I'm going to tell you the latest, and this is straight from the researchers who've been doing this. They came to a symposium that I went to. And that is, one of the problems is that with the opioids, once people were starting to really misuse it, a lot of people then decided they'd go to heroin because it was cheaper and they could get it easier in some ways. And so that people now, when you're in pain, they went the other way. Then they wouldn't give you anything, And there's this happier medium that we need to get to. And he says it's starting to go back, a little bit more to being a little bit more appropriate dosage. But I'm going to tell everybody there is a 10-day point on opiates that you should, if you can, get off in terms of pain. At 30 days, you put yourself at a hole. You put yourself into a. After that, you start to get yourself much closer to the addiction level. That's the first time I've ever been given days, and they were looking at an aggregate of metadata on people with the opiates. So I'm getting that message loud and clear. And I remember back when my husband had back surgery, way before any of this, he was like, after 24 hours, he was done taking any pain medications. And I thought, I was like, well, give yourself a couple days. But, I definitely get that now. Opioids are not for long-term pain. And so that it's really important that people understand that if they're dealing with...
she stopped working.
Huh?
They tend to stop working.
Exactly. And not only do they tend to stop working, but they get, actually, your ability to handle pain drops. Okay. Just trying to say 47,600 people died from overdosing from opioids. And now we're finding people are overdosing, and then they're coming back because we now have the Narcan, which is good. I'm not against Narcan. I'm not against giving it to them 10 times if we have to. But but now they're overdosing much more. Now I hear that, you know how you have the person who's not going to drink be the designated driver? Now they have the designated person with the Narcan. So, yeah.
We brought folks back and had them curse us because we interrupted
Their
their
high.
buzz.
Yeah.
Yelled at. What did you do that for?
Yeah.
Anyway.
No, but then, yeah. And they're dead. So, anyways, and you're right, because it totally, it fills the receptor that had the opioid attached to it. Okay. All right. So just that, obviously, 2 million people misuse prescription opioids for the first time. Okay. All right. So there are several strongholds that keep a relapse a more likely outcome. Oh my gosh, I can't believe I do that. Sorry.
The problem when you do that, at least where I'm sitting, is now it's reflecting the trees. Can you, I don't know about the rest of you, can you slide it just slightly this direction?
Yeah.
Perfect, thank you.
Okay, good. All right. And then now this a lot of this is writing, so I'm going to hopefully be able from this point on. But there are some of the strongholds include structural, supportive, protection, developmental, and spiritual realms. Those are very important that you want to make sure that you have involved. Back in 2008, I did a study, and my study was on looking at a community response. And that was talked about with Quinonia was community last night. But in looking to do a community response, once I did the research, I'm like, I understand why people stay addicted, because it's too easy. There's too many places to drop off. And I think one of the biggest things that I want you to also understand is there's a thing called PAWS, which is post-acute withdrawal syndrome. What that means is cravings are first and foremost for addicts, and post-acute withdrawal lasts up to 18 months, easy. Yes.
It's so important to engage the one that's in front of you with why they're doing what they're doing. We begin with judgment and then write a prescription for them for how they're going to fix their life. But let's see, what is it? I can't remember when this came out, but motivational interviewing. When I first heard about that, I read the book and I asked a guy, so tell me, what is it you like about heroin? And it was just revolutionary with this guy, because he engaged for quite a while there what it was that he really liked about heroin, and described to me why he continued and why it would be difficult for him to quit in an open way that I've very seldom heard, without sort of priming the pump by giving them the platform to say why they like it.
Absolutely.
And he
you
actually
engaged him.
Yeah, he actually ended up, this particular guy did end up getting sober, and he getting clean, and he has persisted. He lived.
Yeah. That is wonderful. No, I love those.
Doesn't always work that way.
Yeah. I noticed that nutrition is not part of your list here, and one of the things we've discovered is there are two primary biochemical drivers of post-acute withdrawal. One is hypoglycemia. Stats are showing that above 80%, and I do mean this, we need a lot more research, but the stats we have currently are indicating that way up there, number of addicts as well as alcoholics are medically diagnosable with hypoglycemia. That means the blood sugar can go very high in response to sugar, and many opiate addicts eat a lot of sugar, but then it drops very dramatically, extremely dramatically. Well, the body's response to that is adrenaline. And adrenaline puts the prefrontal cortex offline, and this is where we store our recovery skills. And so a lot of the symptoms of post-acute withdrawal are actually the symptoms of hypoglycemia. The other set of symptoms from post-acute withdrawal is neurotransmitter deficiency, because of course your neurotransmitters are very depleted. And we know how to address that now using over-the-counter amino acids. We can turn around post-acute withdrawal symptoms within 20 minutes. And so we actually now have an answer to, not 100% answer by any means, but we have some significant answers to post-acute withdrawal that significantly drop relapse.
The N-acetylcysteine.
N-acetylcysteine is included in that more as a underpinning.
Okay.
And yes, and you will see that later on I do address nutrition, but I would love to see what you've got. Anyway, so I could use.
We have found, for instance, that missing a meal is probably the #1 relapse trigger for all addiction, because of what happens in the prefrontal cortex, which is our executive functioning, right? Our recovery skills. What happens here after we miss a meal, and it's dramatic and profound. And so many people have, when they report their slips and their relapse, say, "Oh yeah, I missed a meal or 2 or 3. I missed a meal or 2 or 3. Oh my goodness!" And then once they start not missing meals, their craving drops dramatically.
Okay, that's very good to hear. And I also don't know that I mean, one of the things is we're always, when you're using, it's always going to the limbic system. It's always going to the amygdala. So I don't know if maybe the meal stop is also preventative.
It is preventative because the amygdala is tied into sympathetic arousal and adrenaline. When blood sugar drops too low too fast, adrenaline kicks in. And adrenaline throws us out of executive functioning into sympathetic arousal.
Yeah.
Kind of the opposite of that thing is in a lot of gastric bypass patients, we're seeing addiction transfer, where they're used to having meal, and then suddenly you've made their meal receptacle smaller, and so now there's this addiction transfer where post-gastric bypass patients are now gambling addicts, they're shopping addicts, they're drug addicts, they're alcoholics, and so I'm not surprised that the opposite would be true.
It's exactly related. Yeah.
Wow, I need to pass that on because we have. There was somebody who was graduating from drug court, and we tried to talk her out of the gastric bypass, and she got it.
Yeah.
She got it, and so I'll keep my. But I will pass that on to her.
You know, stressors are stressors.
That's true.
You know, you anything can kick you back.
Yeah.
And if it's a voluntary thing, like something like a gastric bypass, well, good heavens, that's a pretty big stressor in your life.
Yeah, I'm also wondering about, even the majority of people who go into residential treatment are not going into the treatment centers that are kind of the Hilton,
feed you well.
Right. Yeah. They're going into less than ideal programs that are limited in their funds, and I'm wondering even what kind of food the meals that are being given to them.
It's actually pretty dreadful.
Yeah, that's what I worked in one.
Is they switch their addictions to sugar.
Right.
And sugar is actually an addictive drug.
It is.
I mean, it fires all the same neurotransmitters, and they've done studies where they've gotten rats addicted to sugar, then withdraw the sugar, and they have opiate withdrawal symptoms.
Right, I saw that.
Yeah,
but even just basic nutritional, to
rebuild your neurotransmitters.
Even with glucose, like you were saying, and then just wondering, that could be an interesting thing. One of the things that I've seen over the years is that a lot of the ODs they happen because they go in for 6 weeks, 8 weeks, maybe 12 weeks, and then they graduate the first time, and then they're going to have and they go back and shoot up with the same amount of heroin, not knowing, not knowing that this is what's going to kill them.
Yeah.
Right. That's kind of
Yeah.
I'm going to bet that that's 50 to 60% of the deaths from heroin are
That's a
from
good
that.
point.
Yeah.
You know, because they're going to have a permission-thinking thought that says, "I've been a good boy or girl for 2 months, and it won't hurt me once if I go and shoot up," and then they're dead.
Right. And that, when I did, back in 2008,
Yeah.
when I did my original research, is some of the things that I saw. And so that's one of the things I want to cover today, are all the different ways that we can look to try to, and nutrition's right up there.
It has
So,
to be.
Yeah, I totally agree. So one of the things that we're going to look at now is structural. Okay. So treatment, there's a very big point in saying the importance of a great assessment and education to the client. At some of the places where they're going, you want to make sure that they do a thorough assessment. And I don't mean just like sit there your first day and just do paperwork. I mean over a period of time that you're giving them a lot of different measures to be looking at. And I also believe in the ASAM for the assessment as being gold standard in terms of making sure you've got a great assessment.
Can you elaborate what is that?
It is the American Psychiatric
American Society for Addiction Medicine.
Addiction Medicine.
Yeah.
That's it. Yeah. And they now, I'm now going to be transferring over towards being able to do that on the computer. But it's not cheap to go to that. But ASAM really is the gold standard because ASAM looks at 6 different areas. One of it, which is, are you in a possibility of going into withdrawal? What is your stage of readiness? So it's that assessment. A warm handoff from detox to early recovery. Too often people go through detox and then that's it. They think, oh, I just go once a week. You want to make sure you're involved in something that deals with the recovery. A plan for mid-level recovery. Mid-level is definitely in itself kind of a way of maybe getting back on to heroin, because one of the biggest works that you do in recovery is you work to get those triggers identified. And people just can't say, oh, I know this is kind of my trigger and think they've got it all. And a lot of times they're not ready to admit to some of them. Some of the triggers are people, places, and things, and people don't make that change very easily. So mid-level is very important. And then counseling centers that remain focused on strong addiction programs. One of the things that Choices does is we do a lot of individual work, and we're not as big on groups. It didn't necessarily start out that way. It wasn't our what we thought, but we're finding it's very successful. But it needs to be followed by more than that, and I'll tell you about more than that in a little bit. But one of the things individual counseling does provide, and I'm not talking about once a week, kind of as being it. But one of the things that individual does is it does not let you sit in the back of the room and not get involved in there. And it also really helps to pinpoint. And I'll talk about some of the ways.
Trauma.
Absolutely.
Yeah.
And then government. The police department, early responders, emergency responders, hospitals, the trustees as resource builders, providing resources, and the mayor council programming. What we have is I'm in partnership with a place called HealthLink, and they just got a $1.5 million grant, okay, and they have our recovery coaches. So that's the other thing I'm going to be hitting very hard on, is talking about recovery coaches and how important they are. But what they're doing now is they're having their first responders. So when there's an overdose, the recovery coach goes. It's a team. There's like 4 people who go to that call, And then there's a coordinator who then does a assessment, and then they bring in the recovery coach who comes in as they keep, weekly, every week, and they see that person. One of the things when I did the study back in 2008 is I felt the importance of having teams of people whose their family members have been through this and are in recovery. They would be great to be able to talk to family members of those going through it now, because they're going to say, watch out for that. When they tell you this, they're getting ready to use. They've seen all the stuff. They've had it all happen to them. They kind of, it's really nice to have that support.
We would always just cut to the chase. How do you know when an addict is lying? An active addict is lying whenever they open their mouth.
Yes, there you go. Yes.
That's why we were saying that you have to have the blood test done. If they're in an active stage of an addiction, it perpetrates itself, through the need to be false. So
and they're thinking and they're smart.
Uh-huh.
They're smart.
Oh yeah.
Yeah.
I was on the ACT team, the Assertive Community Treatment Team for Santa Barbara County, and I had a young man who was absolutely brilliant and had been a heroin addict and opium in all its forms. And he was a gifted chemist also, and literally could just, he had it down. And when he overdosed, he finally did, he chose overdose. Mm-hmm. And it wasn't an accident. It wasn't a hot dose that he accidentally got. He'd have these suicidal ideations, but so rationally, and just, life is a mess, and this and that and the other, and all these issues. And we'd play chess together and talk. And
wow.
And then I ran into his mother after I had left the team some months later. I always knew he probably would at some point, but it was almost this rational choice. It wasn't this just random, accidental kind of thing at all. He was playing it close to the edge, and then decided to step over.
And you knew that he.
I knew it was coming.
Yeah. Yeah.
Still breaks my heart thinking about it.
They are such sad things. There was a guy who was at a halfway house, and he was like the model child. And then he left. He finished and everything, left, and I think he didn't find his place. And from that, I've kind of decided that anybody who leaves drug court, we prepare them as they're in their last phase. We try to prepare them for being out ahead of time, so we can get to see. Because he did it within the carotid artery, so we knew that there was no. And he had overdosed, so yeah. So it's important, though, in terms of having the government is being involved in this. My company we're now going to be going into LaPorte County jails when people are there, because the jails are filling up. Surprise. And so what they're looking for is that they start 30 days with us, and then they continue with us afterwards. But then the judge will, we'll let them off, not without anything, but at least they can then leave jail if they've been able to show that they're making changes. Because one of the things we do is we don't care that you went through our program. We could care less. We care about if you applied it, and we check for application. If you're not applying what you learn, then you didn't pass our class, because it's not a class, it's individual, and that's what we try to do. But community is also important, and I can't say enough of that, and I wish I had more nutritionists. I would just do backflips to have nutritionists.
I
love that.
I run an online school teaching clinicians these skills.
Well, we got to talk.
There you have it.
Okay. We got to talk. Support system of the recovery coach. The recovery coach is what I call the action arm of the treatment plan. I can be talking with them. We can be, digging up stuff. We can be doing all kinds of stuff. I need to know that there's the action plan. We can talk about getting a job. That recovery coach will drive them. And, they'll look at the resume. They'll do all these things. I cannot tell you that if I see a recovery coach that says we worked on coping skills, I just go, what did you do? I want to know what coping skill. I want to know what you worked on with them, and I want to know that you've then measured it the next week. So it's just not like, okay, we got a recovery coach. That recovery coach has an actual job to do that should be tied towards change, because that's what we're working for. The first thing we work for in substance abuse treatment is sobriety, okay? The second and hardest thing we work for is a sober lifestyle. Two different things. But anyways, back to community house. Problem-solving courts. Yes?
So where does the financial support for this come from? Because I take care of, I'm actually an infectious disease physician, but I work at a community health center with, gay, lesbian, transgendered individuals, and a lot of people who are HIV infected and substance users, et cetera. We have a lot of homeless and a lot of people with, even though we have Obamacare, they still aren't able to really get into it. And we just don't have, we do have a substance, an addiction team, but it's the financial support of it all.
Always, I agree.
So do you have resources for
Yeah. Well, let me tell you a little bit about what's going on. So, for instance, I think it takes a lot of work. Now, I'm in Indiana. So in Indiana, we have recovery works. If you're a felon, you get so much. But it's funny because you got lots of support, and then now it's like, oh no, now only nothing more than 10,000. No, nothing more than 2,000. No, it didn't take them long. They couldn't wait to get more people signed up for recovery works, and then when they did, some idiot did $1 million worth, and they messed up the funds,
But there's, actually, if I'm correct, I haven't. You can go directly to SAMHSA, and you have to and file for your own. You have to have a plan. You have to not have a.
So SAMHSA has.
Yeah, there's a ton of.
But
resources on there.
I will tell you that the grants are not that easily. They give out 6, and they do.
Yeah.
Honestly, they are good. But I will tell you that we did a grant for the county, and they have hospital funds the hospital was sold that money, and the doctor said that we were too aggressive in our grant. So that we tried to do, we thought we were going to do too many things, so I don't know, but we have recovery work, so that's one thing. Mm-hmm. The other thing is that we have Indiana HIP. Indiana HIP does pay for individual sessions, and it pays for group sessions. We also have, now that we've kind of partnered with HealthLink, which is an FQHC. Is that you got the letters right.
What does that mean?
Federal Qualified Health Care. Yeah. Okay, they're the ones who got the $1.5 million.
Of course,
So there's money for FQHCs?
Yeah. Oh, big time.
That's actually. It's all how you write the thing.
Yeah.
And they only have to $1.5 million. They have to see 75 people in a year's period.
Well, that's pretty good.
Okay.
We just got FQHC approved, so maybe we can.
Oh yeah.
Oh, your life
That
will
opens
change.
the door.
Yeah.
Your life will
Yeah.
change. You just need to get some good grant writers.
You do.
Yeah, that's it.
You
Yeah.
do. You got to get good grant, and that's what they, that's what they put their money in. Is they found a good grant writer, and now they're starting to really hit their
I hope that as addiction starts to be more and more viewed as medical diagnosis and less as a criminal act, like the criminalization of addiction, I think contributes to the lack of funding. I'm from Cleveland, Ohio, and we're starting to turn the corner. I really think we're starting to turn the corner as seeing this as it's a diagnosable illness,
right,
and not so much as something that you just have to punish out of people.
Right.
So I'm hoping that the funds will follow once this is starting to be seen more and more.
And research is showing that with heroin addiction or opioid addiction, that they're gonna it's being looked at primarily through a medical model, but that which also has some problems that I think it's a little lopsided, but it's also being looked at as a chronic. A chronic disease,
Chronically relapsing disorder.
well, that's the whole idea that if we have 12, 18 relapses with somebody in the space of 5 years, and we're not looking at this disease perhaps from the right angle, so we need to look at it from the standpoint of a chronic disease, and if we do that, then we have different aims.
I could not agree with you
Yeah,
more.
yeah.
Now, 5 years is viewed as for cancer
Right.
as the amount. I will tell you, all the research I'm looking on substance abuse is saying 5 years.
Yep.
And I don't mean that they're relapsing up on the 4th year, but I'm saying that in terms of really creating that sober lifestyle, 5 years.
But it's chronic, it's all of those things, and then it's comorbid with whatever.
With whatever. And then
five
throw in a
different-
little bit of trauma.
Yeah.
Or a lot of
A lot of
If
trauma.
there's any problem, well,
Are you familiar
one,
with
two, three,
reward
four,
deficiency
five.
syndrome and the research by Dr. Kenneth Plum?
I'm not sure about him, but I am reward deficiency, yeah.
Well, he's the person who initially discovered it.
Okay.
For those of you who may not know, reward deficiency syndrome is one of the theories being posited right now as part of the genetic driving underpinning of addiction, because these researchers have identified the SNPs, or genetic polymorphisms, in the different neurotransmitter systems. So when you're talking about dopamine, there's this dopamine reward pathway. Well, that ends up in the firing of dopamine, but all the neurotransmitter systems are involved in this pathway, are involved in the firing of dopamine. If there are issues, glitches in any of the pathways in any of the neurotransmitters, it's going to impact the firing of dopamine. So by looking at and they have an algorithm, by looking at the combination of genetic SNPs in these different pathways, there's now some solid research indicating that we can predict who is susceptible to addiction to which drug, and also which behaviors are also driven by issues. Behaviors and mood disorders are driven by issues in these different neurotransmitter systems. And there is a new genetic test called the GARS. It's way too pricey for what it does, but it can identify the 10 driving SNPs in reward deficiency syndrome. And it can predict whether somebody is going to be more susceptible to becoming addicted to your opiate medication after surgery versus the person who's not. Very, very fascinating stuff. But anyway, go on.
Yeah.
But I'm glad to see that. Go ahead.
Oh no, like I'm interested in some of the I'm taking right now a course on trauma-informed creative arts therapies, and what we're discussing now is like all of this research of like, okay, trauma, addiction, this is all really big, this is a buzzword, how do we treat it now? And we are looking at these things, it seems like it's just these isolated, so, okay, if we give them this kind of diet, then it'll fix their addiction, but then they'll like, okay, we know the genetic code, so if we can treat that, but as from an orthodox perspective too, my concern is like, what are the driving factors that now contribute to the reason why you're addicted, because you could be on whatever.
What's a biopsychosocial spiritual disorder?
Right.
It's a three-legged stool. It's never ever one-legged.
The other thing too is that, I mean,
Yeah.
when he spoke of comorbidity and
Comorbidity, yeah.
comorbidity, but you have co-occurring things. Women who develop alcoholism, alcohol use disorder, very often are accommodating with depression. Men who have a serious general anxiety disorder will also develop, alcoholism as a accommodation. We haven't really treated it symptomatic. So I mean,
You
it's
can't separate
Well,
it out.
Yeah.
well, what I want you to hear is what I'm putting. I'm
Yeah,
glad you
yeah.
said that, because the
Yeah.
point I'm trying to make is I'm bringing out all the different areas we got to look at, and I agree with you 100% on that. So I'm saying structural. You've got to make sure you've got the structure in place to what you've got. You want to make sure you've got your supportive system in place, and supportive system is the recovery coach. It's the family or surrogate family members, and when we're working with the jails now, we're asking to see the family members too. So we're all on this team, okay? The support system of families who've been through the process to fortify those new family members. The self-help groups that continue to grow and sustain their organization, NA, AA. They serve a purpose because they give you different people. That's, again, you're working towards that sober lifestyle. That means you got to build your support system.
We should put church in there.
Huh?
We should put church
Informal
in there.
education.
Well, you haven't gotten to that yet.
Community,
Okay. Community that provides skill building opportunities on a volunteer basis. Again, anything in terms of nutrition or yoga or a lot of other things. Informal educational opportunities. Anything you can open up their life to is going to be helpful. Developmental. I will tell you that this is one of the biggest things we've ever dealt with. I look at what age they are, and one of the ways I look at what age they are is I look when they started heavy into drugs. I guarantee you, if they started heavy at 13, I'm looking at a 13-year-old. Okay, because they didn't make the developmental steps they needed to make in order to move forward.
It just halts it.
It absolutely halts it.
And that's usually when the trauma kicks into. There's going to be trauma, and then
You're not going to be successful in school. You're not. I mean, there's just one thing after another.
Right.
So you consider assessments as doors to the developmental issues the client faces and needs to resolve in their path towards recovery. Your developmental milestone hits and misses. Educational development and pathway, obstacles and achievements, emotional development, age the drugs became the focus of the person, trajectory of their usage, at what point did it go crazy, attempts made to stop, when were they, how often were they, barriers through the judicial system, and familial developmental hits and misses. Spiritual. We're looking at recognizing a power greater than ourselves, which is grounded in love and compassion. It's a power that gives us perspective, meaning, and a purpose to our lives. It's a desire to connect with more than ourselves, to connect with everything. Okay. Impact on those with a focus on spirituality. When spiritual people, you can see, are gracious and grateful. They're compassionate. They flourish. They consider personal growth and fulfillment a central goal in self-actualization, as it requires people to focus on themselves internally and work on being a better individual and take time to savor life experiences.
That's nice.
Thank you. The human condition is heroin addicts will say that heroin robs them of their soul. Emerging trends require the fulfillment of a lifestyle that is wellness-based, there we go, throughout that wellness wheel, and which quenches the unrequited quest for more and more. You can never satiate a human being. That's our downfall. Okay, we're never going to be happy enough, and because we always want more. That addiction is always trying to attain, but miserably fails at attaining. It's the same issue humankind views, not unlike our ancestors of always wanting more and more and inability to be fully satiated. Spirituality is that critical piece whereby the goal of satiation is no longer front and center, while the quest provides a path forward toward growth and communion with God. And then
which never gets satiated either.
but at least you're always moving forward. Addiction, understanding the roots of addiction, slippery slope, the Orthodox Christian theological understanding of first sin. Briefly, the Orthodox teach that the fall of Adam and Eve is founded in a crisis of love, in where they freely choose to disobey the Lord's directives in the garden, desiring or loving to be God without God. By ignoring the directive of the all-compassionate God in the garden, our foreparents chose inauthentic relationships so they would become God without God, seeking for themselves his position and power. Orthodox Christianity traditionally identifies this same phenomenon as the sin of pride. Addiction involves, it's a disease, and no one is unaffected. So if a healthy cell mutates over the course of time into a cancerous one, the end product represents the addiction in its full-blown and most visibly destructive, deadly expressions. All the other intermediate stages between them involve a degree of sickness, and that's what we have to consider, continuously look at. And attachments and the passions undergird every addiction and addictive process, and that's something we want to look at. Addiction, again, involves that it's an authentic relationship. It's all about an authentic relationship. 12 Steps tries to help people do that. Confront our addicted random thoughts and concepts, and that's where I use Gorski. I'll show you the book before you leave. I actually trained under Gorski, and the guy's brilliant.
So did my husband.
And Radical Humility. Good, I like it. And then finally, practical application and how it differs from what we're doing now. Find your starting point and network to build a more robust, consistent, and sustainable hub. That's what we're always working with them. What did you do this week to build your hub? And the recovery coach helps them along the way. We bring in family. How are they helping? So you see, it is complex, and we need to be complex in the way we're handling it. Evidence-based, by the way, and I got 2 more slides. Practical application and how it differs from what we're doing now. Part of our work is to guide the client in their journey toward a life of recovery. In their journey of recovery, the client moves toward sobriety and from there to that sober lifestyle. The sooner the client makes these changes, the sooner the client experiences positive results. And then the more you do that, the more you stay on track, the more you're more likely to have fewer relapses. Part of building the sober lifestyle is active participation in self-help groups. I can't say that enough. Okay, so now we've got here questions that you need to. What structure must you build, and who else necessitates partnering with, and thus begins the process of networking? That's what we've begun doing. What supportive systems will you build into your agency, into your hub? How will you both assess and treat clients in their developmental growth? How will you promote and utilize self-help groups? How will you help the client to connect the dots and achieve growth in the developmental growth? How will you help the client to sustain growth with each major step they make? And how are you using your curiosity, knowledge, and prayer in helping to keep you abreast of the trends that are working and the increasing level of knowledge on addictions that you need to continuously have? I heard in here amazing knowledge and amazing curiosity. So I walk out of here really thrilled to have met you all and to have seen where you're going with that. And how are you building joy into your work and life?
That last question is really, because when I'm working, you have some really important focuses, or even like I call them scripts or models, and you have to say addiction, recovery is not about taking something poisonous out of your life. It's about putting something back.
Yeah.
So until you, and they have to be the ones that find out what they're going to do with that, and putting those positive, like what you're saying, beautiful things back, that will also, bioneurologically, over the long-term recovery, build, that whole, neural build. You have to build new neural pathways.
And it does. It builds.
Neuroplasticity.
Yes.
And so and so it takes time. That's why we're talking about a chronic disease. but
takes time.
it has to be putting something back into your life that is going to be beautiful, positive,
Right.
and meaningful.
Now I'm going to make one little
Yeah.
commercial, even though I mean everybody gets to decide what they want for themselves. But I am a big Vivitrol proponent. I'm not a methadone proponent, but I am a Vivitrol component, and I'm the shot Vivitrol component because when people get the Vivitrol shot, it's there for 28 days. It helps the cravings,
Buys time.
and it buys them time to get through. So then, the sooner they move forward, the more clear thinking they are.
Wish it was
My
cheaper.
only concern with
Wish it was cheaper.
Now, see, check with the your pharmaceutical rep because in Indiana we got it pretty cheap. Yeah, it's like $25. I'm
We'll
serious.
send all of ours to Indiana.
Yeah.
I know. Send all my patients to Indiana.
I'm sorry to hear that though, because ours is at
Unless
25.
you get like good, even like some insurance will cover it, and because where I am at, I work at a clinic on the near west side of Chicago, which is like we have second highest heroin deaths.
Oh,
So-
see,
So yeah, but so we have a Suboxone program which really helps. I mean, we actually had our Suboxone providers are all maxed out already, and we can't keep up with the
Yeah.
number of providers certified to do Suboxone. But
I would start talking to your state senators and stuff. I mean, maybe not you, but I mean, but this is where community needs to get involved.
You got to build will.
You have to. You
we
have
also
to.
have a lot
Oh,
of undocumented
and that's what I wanted to tell
can't
you.
get a lot of stuff.
DCS is talking to us because I'm working with the dean at the university because they think they can save money with our program.
Oh yeah.
So
That's how you write a grant.
That's
Yeah.
You've got to be able to say, we are going to save you $500,000 over the course of this,
Yep.
And here's
this
what it's gonna
period
look
by
like.
doing
Yep.
these things, and we're going to evaluate it and blah,
Yep.
blah. That's
But
all.
what
Yeah.
what we built into it? What
Yeah.
we're saying, we will not do it unless they let me have my evaluator have time be paid for their time for the evaluation. Because I'm like, you know what?
Yeah.
Prove me wrong. I'm fine. You know, then we'll come up with something different. But
Yeah.
I want my evaluator paid. I want me paid because I will be the one working with the therapist.
I do think, go ahead.
Well, one of the things I wanted to say, going back to when I interrupted you about the community and church, is that I think as members of churches and as churches, we can all do a better job welcoming people who are struggling with these issues as part of that community support.
Yeah.
Because some churches really do consciously try to welcome people who are struggling
Yeah.
and who are on the edge and who are obviously not okay.
Yeah.
And other churches don't do such a good job welcoming people who are obviously not okay. And I think as Christian community, the more we can find ways as a church community, and this is part of the structure of the church, right? Because there's
Right.
always one or two people who are doing it, but how can the structure of the church be, I don't know, whatever the word is, to really include the disenfranchised?
I think too that what has to happen in the church communities themselves is that they recognize that there are already people in those communities who are
Already
participating in 12-step groups outside of that church and don't want to do it inside of the church because the church could be such a place of judgment.
Well, we got
Right.
stigma.
So to remove the stigma, and then in my community we have 3 recovery groups a week.
That's lovely.
And then I do even, in my office in the church too. And we want to expand to do for the community. But I have my people, my own members. I've got one man who's 35 years sober, and was ex-mafioso on the south side of Chicago. And this guy's the godfather of recovery in South Chicago.
Yeah.
I mean, we have 150
What stronger
people.
voice?
Yeah.
Yeah.
What stronger voice? Yeah.
Yeah, I mean, he he's just amazing. I took him to Romania with me to do addiction recovery for the program there with their church.
See, and I think education of our parishes, of our parishioners,
Right,
because
they're already
people
there,
who have not been directly touched by addiction, and even some who have, don't get it,
Right.
right?
Or they're just lying. There's not a single family
They don't know.
that does
Right.
not
I gotta
have
tell you something.
some kind of
Yeah.
addiction,
At
you know, in
this
that
point,
family.
I usually say
Yeah.
my last opium use was in 1972.
Yeah.
And I go regularly to either NA or AA meetings, and it's quite well known in Santa Barbara County that that's part of the package that you got when you got me, and because I've been there a long time, and I found, you know, you could say, are you being nostalgic? Are you being prideful? Well, I'm being, I hope, I pray, incarnational somehow.
Yeah.
In identifying, what's that French word that Doctors Without Borders, témoignage, where you stand alongside and bear witness. And you don't necessarily fix the problem that's presenting, but
You bring hope.
Yeah.
you bring hope.
My recovery people in church are the most spiritual people that I have in that
And
community.
I love the
Hands
ones I've got.
down. I mean,
Because they're honest.
well, they're honest, and they know how, you know, how much how much this it's just a disease.
Yeah.
You know, so